Let's begin with basic airway skills. The first two steps in any airway management response involve opening and clearing the airway. First, open the airway using a head tilt, chin lift. Placing one hand on the forehead and one hand on the chin, push with your palm to tilt the head back while lifting the jaw to bring the chin forward. This simple maneuver lifts the tongue from the back of the throat, opening the airway. This procedure is safest on patients without any evidence of head or neck trauma. In patients with suspected cervical trauma, a jaw thrust without head extension is used. In a jaw thrust maneuver, place your fingers just under the angles of the lower jaw and lift with both hands, displacing the jaw forward. However, if the jaw thrust does not open the airway, use the head tilt, chin lift, because maintaining a patent airway is a priority. The second step is to clear the airway. Here, suctioning may be necessary to remove secretions or foreign material from the mouth and base of the tongue. Use a large bore, non-kinking suction tube and a large suction catheter with a semi-rigid pharyngeal tip. High suction pressure may be required. Once the airway is open and clear, you may consider an airway adjunct to maintain patency. There are two main types of airway adjuncts, the oropharyngeal airway, or OPA, and the nasopharyngeal airway, or NPA. OPAs are commonly used for patients who are unconscious and have no gag reflex. NPAs may be used for conscious or semi-conscious patients who still have a gag reflex. The OPA is a J-shaped, single-use, disposable plastic device. Here's how to choose the correct size OPA. When the flange is at the lips of the patient, the tip of the airway should be at the angle of the jaw. OPAs are available in various sizes, with the most common adult size ranging from 8 to 10. One method involves inserting the OPA with the tip pointing to the hard palate. Rotate the device 180 degrees until the tip touches the posterior pharyngeal wall past the uvula. Alternatively, the airway can be inserted sideways and rotated 90 degrees into place. Once properly inserted, the OPA holds the tongue away from the posterior wall of the pharynx. If the device is inserted incorrectly or is too small, the OPA can push the tongue against the posterior wall of the pharynx, actually closing the airway. The OPA also provides access to the throat for suctioning and prevents the patient from biting an advanced airway. Only healthcare providers trained in the proper use of an OPA should attempt its insertion into unresponsive patients. The nasopharyngeal airway, or NPA, is a soft, curved hollow tube that can be inserted through the nostril to facilitate ventilation. To choose the correct size NPA, place the flange of the device at the nostril, and the tip should just reach to the tragus of the ear. To insert an NPA, point the tip of the device away from the maxillary bone. Using moderate pressure and a gentle spiral motion, push the device into the nostril. When inserted correctly, the NPA should reach beyond the nasal cavity to the pharynx, providing a clear path for ventilations. If you feel an obstruction during insertion, gently withdraw the airway a centimeter or so, rotate it, and gently try to insert it again. If you continue to encounter resistance, withdraw the airway completely. You may try inserting it in the other nostril. Use caution when inserting the NPA in patients with severe head trauma. With a known basal skull fracture, an oral airway is preferred. The NPA can be inserted in patients who are awake or who have a cough or gag reflex. After inserting either an OPA or NPA, it's important to check whether the patient is getting adequate ventilation by listening for breath sounds.